Everyone, I'm Dr. Marilyn Brink. I am Medical Director at Animal Emergency and Specialty Hospital in Grand Rapids and in Byron Center, Michigan. I am speaking on behalf today of Dr. Matt Booth and Dr. Rachel Halpin, who worked with me on a survey looking at veterinarian scheduling for retention. So today we're going to talk a little bit about the insights that we got from the survey study. This presentation was given at IVEX 2024 by myself and Dr. Halpin, but I'll be just presenting it today on her behalf. First, we're going to start with some background of what made us do this survey study in the first place. And then we'll go through the survey data, we'll look at recommendations, and then we'll take those recommendations and put them into action in a real hospital. Let's start with some background. First, our scheduling survey was developed more in response to the DVM shortage. We were sitting around talking about the shortage and the challenges with not only recruiting DVMs, but retaining them. And ultimately, we thought, wouldn't it be interesting if we could really understand the preferences of doctors who are currently working in practice and figure out the impact on several factors on their preferences, such as gender, parental status, the years that they've worked in practice, and if they work for Ethos or not. And we would determine preferences based upon looking at their preferences on shift length, their shift type, the schedule management, as in how frequently is the schedule given to them, looking at their schedule consistency and variability and what they prefer. All of this kind of started associated with a study that was published in JAVMA in 2022, looking at factors that impact recruitment and retention of veterinarians in emergency practice. Dr. Matt Booth was one of the co-authors on this study. And from that study, it did determine that there were 5 buckets that made it more likely that an doctor would be retained in practice. And those buckets included medical support, looking at environmental tone or atmosphere. You could think of that like culture, the schedule, professional growth opportunities, and the leaders within their practice. But today, we're really going to just hone in on the schedule bucket, talking about how that may help to retain doctors. Let's get into the survey results. So we ended with 516 survey responses, and you can see the distribution here of different types of vets, but 82% of the responses came from DVMs. Our respondents' characteristics included a median time in medicine of 7 years. They were 82% female, and 37% had children. Although worth noting, those with children were more likely to have been in medicine for longer, so 12 years versus 6 years in practice if they had kids. And as we go through these results, if I don't state otherwise, it means that there were no differences found based upon gender, years in practice, parental status, or practice type. We asked about if they preferred a permanent rotating schedule, and we can see here that this was their preference. And 20% were ultimately neutral in this area, but 62% agreed or strongly agreed, and asking it the other way, it also confirmed that this was the finding, as 49% disagreed or strongly disagreed with having a variable schedule. And they had an overall preference for working fewer, longer shifts. 84% agreed or strongly agreed to prefer 3 12-hour shifts, as opposed to the preferring of 4 8-hour shifts, with 78% disagreeing or strongly disagreeing with that sentiment. The exception here that we found was that parents were more likely to prefer a 4 8-hour shift than those that did not have kids. They preferred a schedule distribution given to them with at least 3 months notice. And you can see here that 65% were satisfied with 3 months notice, but 22% actually wanted their schedule 6 months or more in advance we didn't see any difference based upon gender, child status, years in practice, or practice type. And we found that they disliked schedules with variable shifts, so such as going from day shift to night shift. They um, 64% disagreed or strongly disagreed with having variability in their schedule. There was a stronger disagreement that was more likely if they were in practice for longer, in that 21 to 30 years. There was a strong preference for shift consistency, meaning like they preferred working a consistent shift. 75% preferred working schedules with consistent shifts. And this was one we weren't sure how it was going to come out, but DVMs with seniority would get the schedule priority. You can see here that 80% agreed that vets with seniority should get higher priority for schedule preferences. And there was a general agreement with that sentiment, but it was a more of a strong agreement between 6 years and 30 years in practice. When we asked about the day shift, you can see here that 63% preferred the day shift. It was the most preferred shift, while the swing shift was considered acceptable for most DVMs, with 73% either preferring swings or being neutral to working swings. So that one was fine with for most. While, not surprisingly, the overnight shift was the least desirable shift. With 39% preferred the overnight shift, or they were neutral toward the overnight shift. Understanding that schedule and our compensation, they are closely linked to each other. We did ask respondents about their preferred compensation model. And you can see here that ProSal was the very most preferred, with hourly and salary close behind that. We asked respondents what was the driving factor that made them want to become an ERDVM. And you could see that that was associated with the type of medicine, while they stayed and were retained in emergency medicine associated with both work-life balance or schedule first and compensation second. Ultimately, the doctors rated that they preferred to be scheduled between 31 and 35 hours per week to be considered full-time. With second place being 36 to 40 hours per week at full time. And we considered that in ER medicine, unlike many other types of medicine, there is a difference between scheduled hours and hours worked. Now, based upon those results, let's get into the recommendations. Number one, we recommend performing local surveys. So while we did this very large survey looking at the broad group of ER doctors, we recommend actually doing a survey of your local group of ER doctors. And this will allow them to see their thoughts on prioritizing preferences by seniority, help to align their team preferences with the hospital needs, and you could even consider a weighted schedule to their preferences. And we also would recommend surveying them on their compensation preference as well, but also consider you may want to educate them on other models, because ultimately ProSal is our most common model that we see in ER practice, but we may have some skewed data there because they may not have familiarity with other options. Recommendation number two is to consider incentives for working overnights. Overnight is the hardest shift for us to fill, but we need to keep in mind that 39% of ERDVMs are actually willing to work overnights because they fall into that box of either preferring at 22% or the 17% that are truly neutral to working them. And some suggested incentives were brought up by our respondents, with the top suggestions being to consider a higher shift rate or differential for those working overnights. Consider giving the overnight doctors fewer scheduled shifts in exchange for working nights. Consider a higher base salary, giving them preferential scheduling, keeping them on an overlap or overnight exclusive schedule, and considering a signing or retention bonus for them. Specifically on the first point of the higher shift rate or differentials, we did get some responses suggesting specific things for that. We heard an extra $10 to $50 per hour, considering a 1% production increase, considering an extra $200 to $300 per shift. Recommendation number 3 was to schedule fewer, longer shifts. As we saw in the survey, the 3 12-hour shifts per week were highly ranked by ERDVMs. Recommendation number 4 was to improve schedule predictability. Ideally, what they would like would be developing a continuously repeating schedule. We keep in mind that the limitations to this are that it may limit your flexibility in your schedule if you have to keep people on the same rotation. And we all know that PTO coverage can be really challenging. So if this isn't feasible, then we recommend that you get your schedule published with at least 3 months' notice. Recommendation number 5 is to reduce your scheduled hours to 31 to 35 hours a week. Some considerations would be scheduled hours are just different from hours worked if doctors are receiving cases to the end of their shift. Keeping in mind that once we finish receiving, oftentimes ER doctors are going to be rounding. We are going to finish up procedures or even abdominal surgeries, and medical records, of course. And these things end up keeping us hours after our scheduled hours. And you could consider that you do have to increase the number of DVMs to fill your schedule if you're reducing your current ones to 31 to 35 hours a week, but you'd have that benefit of improved retention. So the ideal here is that it would be a one-time lift of increasing the number of DVMs you have, but then they actually all stay. And ultimately, ER doctors working fewer hours could be considered a trade-off for being scheduled during evenings and weekends. And those are peak social times for people. So having to cover a lot of those times, working a little less than the average person who's working just day shifts would be considered a benefit. Recommendation number 6 is to assess your current compensation model. And we already touched on this with recommendation number 1 of surveying your ER doctors on this, because compensation and schedule are very closely linked. Consider your pro-sal versus a different option if your doctors have low satisfaction. So ultimately, if you're on a salary and your doctors don't like that, then maybe look at pro-sal because that's the most common. But there are some other more creative options for compensation that you could educate your doctors on and ultimately see if they're interested in those, such as a pooled production model. And ultimately, recommendation number 7 really relates to recruiting because in order to follow some of these recommendations, we have to also get additional ER doctors. And a great way to assist in that would be to offer a structured mentorship program for new doctors. It can help you get up to that higher number of ER doctors so that you can do the rotation that you'd like to. And ultimately, it'll improve retention if doctors are mentored and supported. And teaching improves team culture. Everybody's looking for a good culture. And if you recruit doctors through a mentorship program, you're going to naturally be selecting for people that truly see value in mentorship and teaching. And those people tend to be the type that pass it forward. So you improve your culture really organically. In the last section, we're going to talk about the 5 buckets in action. And in this case, we're going to look at a focus on schedule again to improve retention. And we're actually going to talk about me. So we're going to start with my story in the first 10 years in practice. So I joined Animal Emergency Hospital in 2008, straight out of vet school at Michigan State University. At that time, we were a privately owned 7-doctor ER-only practice in Grand Rapids. And just to state, I was completely recruited by the medicine. I wanted to do good medicine. I wanted to learn how to do things the right way and really practice what I learned in vet school with every patient coming in with a problem. At that point in time, between my first year and my 10th year, our hospital was bringing in between $2 million and $3.5 million a year. And On the front of doctor retention, we really were having some problems. We lost between 1 and 3 doctors a year, which for those of you in management, you know that that can really be costly of $100,000 to $200,000 per doctor that are lost annually to the hospital. And if you look at that over the 10 years, I mean, that's an average of 20 doctors that we went through over those 10 years. But on the front of recruiting, we were doing great. We had an awesome externship program. We had an 8-week mentorship program where the new doctor was matched up with an experienced doctor for all of their shifts, and they received book training during the first few months. We had good medicine. We had a good salary. We were on a pooled production model for compensation that really promoted teamwork. And we were very careful in our DVM selection, really selecting for personality. So I listed here the 5 buckets and looking at those between those first 10 years of '08 to 2017. Everything in green was going pretty well. Everything in red, you can see really could use some improvements. On the front of medical support, we had the great mentorship program. We had a teaching atmosphere. We had many externs that were coming into the hospital. On culture, we had a natural culture of medical support and teaching. Our doctors were hired by personality, so that was good. And we had a really supportive team. We had some issues on the leadership front, though. Schedule had a lot of red. We had very little input on our schedule, and we did a rotation of all 3 shifts always. The rotation also went through the holidays, so it didn't matter how long you were there. You always had to work, for example, Christmas every other year. Our schedule was released quarterly, so we did have that 3 months notice. We did have the potential for long-term PTO requests, but we had a problem with the short term where we had limited trades that were permitted, and there really was no seniority benefit for our doctors, where they got to be on a better shift or they got to have first choice for holidays or anything like that. As far as professional growth, we did get to go to one national conference each year. We really didn't have a lot of opportunity for leadership or advancement in the hospital, and there weren't really opportunities for additional training. We did have the mentorship program. In leadership, you can see there was a lot of red there too. We were kind of treated like we were replaceable. It was a little bit of a top-down style of management at the hospital. But then year 11 came, and AEH sold to NVA in 2018. I took on a leadership role in 2018 as medical director, and my first goal was to improve our doctor retention. And the focus here was really on schedule. My goal was to improve work-life balance, focusing on improving some of those red areas in the schedule in particular, and ultimately to make things feel better for everyone. So looking at my next 5 years, we're looking at those same 5 buckets. And of course, everything is so much greener. But there were some really significant things that were done in these next 5 years where we ultimately we were able to extend our mentorship program to a full year. We added to our DVM extern program and recruited more of them. And we added a summer DVM student internship for those in their first and second year of vet school coming through. We started having more medical support on the front of offering vet CT specialty consults for our doctors. And we started a team consult chat where doctors can chat with each other about cases and get help real time. And culture is still good, really having a natural culture of medical support. And schedule is where we really honed in. We started weighting the schedule by seniority, and we also ranked holidays by seniority so that each doctor was able to select one winter holiday and one summer holiday that they preferred most to have off. And I was pretty surprised by how well that naturally worked out, that there were differences within us on who wanted to work which holidays. And that really allowed us to have better retention, and better retention allows us to have more doctors, which allowed us to have improved coverage for the schedule as well. On the professional growth side, we started doing grand round presentations. We started having cadaver labs. We've had endoscopy training, leadership training. We added ER doctor lead positions. And on leadership side, we really changed the approach to be a little more inclusive and start surveying our team and showing them more value in their input. So looking at schedule, let's go through our recommendations in action. So number one, we started performing local surveys. So every other quarter, I send out a survey asking the doctors their preferences on what's their shift that they like the most. What's the shift that they would really prefer to avoid, if at all possible? What is your very favorite or your most preferred rotation? Do you want to work with externs? Do you like training new doctors? And then we ultimately just grant those preferences by seniority. And instead of just giving someone like a complete exclusive schedule to one type of shift, I just kind of weight their schedule toward what is needed, because that helps keep people away from saying, well, I only do this or I can't work that. And our new doctors, they spend the first couple of years just rotating through all the shifts because there really is value in them mastering and learning each shift, even if one is not their preference. I think that, being on the overnight shift made me a better day doctor, and being on the day shift made me a much better overnight doctor. And then number two, for overnight shift coverage, the recommendation was to offer financial incentive. At our hospital, we do a pooled production model, and that is a natural incentive because every time we see a case, we essentially get a case credit. And so working the overnight shift, you absorb all of the inpatients and you see outpatients. So the overnight doctors and the late shift doctors, they more naturally end up getting a higher number of cases by doing in and outpatient on those shifts. So they naturally end up with a financial incentive. So we really don't have any trouble getting our overnights covered. Recommendation number three was to give fewer longer shifts. Remember, this is going to improve their work-life balance. And in our hospital, we average about 3 shifts a week. They are 10 to 12-hour shifts, mostly 10s. And it did require us to increase the number of doctors that we have on the team to cover everything. But it also allows for unlimited trades and much, much easier when you need time off to get someone to swap out with you. And we have a master schedule in Teams where we just allow the doctors to make those trades, and they just change them to red, as you can see in the picture here. Anything red was a swap that a doctor made with another doctor. And number 4 was to improve schedule predictability, because ultimately this really impacts work-life balance. In our schedule, we really don't have a ton of that predictability. That's in recommendation number 4, but to help offset that, we do release our schedule with 3 months at a time. So that goes out 45 days before the quarter. And so they're getting all 3 months in advance. So their schedule goes out quite a ways that they have so they can plan for things. I also do accommodate all of their time off requests. So they have a long-term calendar and then they submit on a short-term calendar. So they always know that their time off is going to be covered. Because our doctors don't work that repeating schedule, it isn't a problem. We have enough of us to cover the time, and we don't have to worry about someone expecting they're always going to be on the same rotation. And number 5 was reducing the scheduled hours to 31 to 35 hours per week. And this has been a huge benefit for our ER doctors. They're more fresh when they come into work and ready to work because they've had enough of a break. We have to consider that our ER doctors, they're working nights, they're working weekends. These are prime social times. And in exchange, having a little bit less scheduled hours for being away from their outside activities and social time can be a very fair trade-off. Keep in mind, too, that in ER, scheduled hours, they're rarely the same as hours worked because of rounds and procedures and medical records and things like that after our shifts. And at our hospital, we schedule 12 to 13 shifts per month, which is an average of 30 hours a week. We did have to increase the number of doctors to make that happen. We increased our coverage on shifts, so we have higher amount of overlap between doctors while working. And this really improved medical support. So it just kind of fell into another bucket as well, because you have another doctor with you, you can ask questions to. They have improved shift trade options for their time off request, and this has significantly improved our retention. Number 6 was compensation. We ended up doing a survey of our doctors and their satisfaction with our pooled production model, and really make sure we value their opinions on things, and they all voted to keep our pooled production. It promotes teamwork really naturally, since if you do anything on a case, you get credit. So it allows them to just leave at the end of their shift when they're done, leaving a laceration repair for the next doctor, so they also get a credit. And then it's increased the compensation naturally for overnight shifts, and remembering that compensation relates directly to schedule. So that does matter. And number 7, on the front of recruiting, we recommended to offer a structured mentorship program. Our mentorship program really does separate us from other hospitals. It naturally selects for a culture of teaching that goes forward, beyond the one person that you actually mentor. And every year we have had to turn away DVM candidates because so many are interested in our hospital. So what ended up happening? So looking beyond the first 10 years to the last 5, we have grown, and we went from 7 doctors in 2018. We're up to 25 doctors today. This does include the loss of 4 doctors. Luckily, none of those related to culture, schedule, or anything like that. They were all related to personal things. We've added 4 specialists. In 2022, we also significantly outgrew our original hospital and opened a sister hospital in Byron Center, Michigan. And since we rebuilt our original Grand Rapids hospital to kind of be like a clone of our newer 2022 Byron Center hospital. And on the front of doctor recruiting, we've grown that extern program. We have the summer DVM student program, which really allows exposure in our pipeline of new veterinary professionals coming out of school. And we have that mentorship program that is a full year for new doctors. We have excellent medicine, especially with the addition of our amazing specialists, and we offer an excellent salary on our pooled production model. Our revenue growth has soared. We were at $3.5 million in 2017 and have grown to $24.9 million at the end of 2023. In conclusion, schedule has the most connection to work-life balance of the 5 buckets. So it really is a great place to start to improve your doctor retention. So first, start with a schedule survey. We'd recommend scheduling fewer, longer shifts. Consider your overnight incentives. Improve your schedule predictability. Reduce the number of hours you're scheduling your doctors to 31 to 35 hours a week. Reevaluate your compensation model. Make sure they're happy with that. And build out a structured mentorship program. And ultimately, have fun. We did a calendar in 2024 of our doctors in denim for our hospital directors. We do have a ton of fun together. Please feel free to email me with any questions that you have about this. My email address is on the first slide. And thank you so much for your attention.